Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and New York City community. I want to thank everyone for joining us. We're going to be talking about COVID, and for all of you who thought that COVID might be gone, it's not. But when all of you are thinking that COVID might be coming back into the vengeance, it probably isn't either. So I have a wonderful guest, a good friend, Dr. Philip Otterbeck, who's the chairman of the Department of Medicine at Richmond University Medical Center, where I'm working, and also the division head of endocrinology. He's an endocrinologist. And we're going to talk about COVID from a hospital perspective. We did a whole hour show last year about it. And now we're in 2022. And I can almost say, where are we different and where are we not? But I'll ask it in a little different way. I was at a supermarket over the weekend, and I saw one of my patients on Staten Island, and she asked me, how are things going with COVID? And I said, I think a little bit better. And she says, that's absolutely not true. My doctor said things are worse. So the good part is when we go to the hospital, we see so many fewer patients who are very sick with COVID. And we go to the emergency room, things are very different than they were before. But clearly, with the numbers in New York, with rising numbers of patients who've been exposed, many of them asymptomatic or mildly symptomatic, how do you put those facts together? Where do you sort of see us with COVID in 2022?
Well, thank you for having me to talk about this important topic. We've been through a lot as a country over the last 2 years, and certainly on Staten Island specifically. And the hospital certainly looks a lot different today than it did in March of 2020. There were days in March and April where we literally had almost the entire hospital filled with patients who were there specifically for COVID. Now we have very few. From day to day, it ranges from 2 to 4 to 6 or 8. And of course, these people are ill, but very few of them are perishing as a consequence of COVID. Part of that is that we've gotten a lot better in terms of management of the patients that come in with the disease. We've learned a lot, but also a lot of the patients have been vaccinated and have had COVID in the past, so they have some amount of immunity to the disease. So if you come in our hospital, it will look like it always did. We are seeing patients admitted to the hospital for typical conditions, heart attack, strokes. These things bizarrely evaporated during the COVID pandemic. Part of that was probably people were too afraid to come to the hospital when they had these conditions. But nevertheless, our hospital looks as it did prior to COVID, with some areas that are reserved for people that are affected by COVID.
Tell us a little bit about protocols in a hospital. We belong to a major university hospital in New York City. And the idea in the hospital, everybody wears a mask. Mm-hmm. Is that when you go out, though, to, say, a supermarket, a movie, a lot of people are not wearing masks. Why would hospitals have different requirements than other places?
It really is a great question, and it almost seems weird. Why would we have one set of rules for one location and one set of rules for a different location? And there's a variety of different ways to think about it, but one of the way I think about it is, first of all, we need the hospital people not to get COVID. What happens is when hospital workers get COVID, they're not able to work. And we need nurses, doctors, aides to take care of our patients. So when we decrease the amount of staff that's taking care of patients, of course, that can affect the care that we deliver. So we want to have our full complement of staff there at all times. So whatever strategies we can implement to decrease the transmission, of course, we're going to take that action. But in addition to that, we have specific types of patients that are under our care. We have patients that have cancer, receiving chemotherapy, and it is very important that those patients not get COVID. And so we're going to do everything, of course, possible to decrease that risk for transmission and from person to person, and certainly from staff to patients. So that's why the rules are both for the state and specifically for our hospital that all staff must maintain mask wearing at all times while delivering clinical care.
Sure, and the different kind of masks. I mean, everyone was talking about the N95s, and we usually come in with a regular mask, almost a surgical mask, but if I'm going into a room with a patient who does have COVID, then I'll put on the N95 and the whole gown. So tell us what, and this is really more to make people feel comfortable. If you're going to the hospital, you're visiting a hospital, visiting a loved one, or working at a hospital, tell us a bit about those protocols that are still being done, again, disinfecting rooms and places to keep us all safe.
Sure. I mean, masks have been with us for a couple of years, and I don't think the public ever thought that they would know so much about masks and N95, KN95, surgical masks, cloth masks. We've learned all this terminology over the past couple of years, and certainly the masks that you see, the cloth masks, tend to be the least effective. When we go into a patient's room that has COVID, the expectation is that the provider will wear an N95 mask as well as a face shield. And the purpose of that is to prevent the particles that could be circulating in the air, COVID particles, from infecting the doctor or the nurse or the other staff member. So an N95 masks are the most powerful at preventing transmission of COVID. KN95 masks, surgical masks, these work, but not as well as the N95. So that's why when you know with certainty that the patient has COVID, that's the mask you would be expected to wear.
Tell us about hospital policy. First of all, should someone be afraid to go to the emergency room now?
So no, the emergency room is a place to go for emergency care. Now, I would not suggest going to the emergency room for a cough or a cold. And I would probably have that same advice now as I would have any other time. Those problems are best handled through an urgent care center or best with your primary care physician. So in the emergency department, patients are expected to wear masks, staff is expected to wear masks. If there is a problem that requires emergency care, whether the patient is having chest pain, shortness of breath, whatever the clinical condition, if you need a care emergency, you should turn up at the emergency department.
Now, what about visiting someone? If someone is sick and you want to visit a relative, things have changed over time. I mean, sad to say, early on, so many of us if we had a relative, weren't able to visit them.
Yes.
Or one person could come, or it was very limited the amount of time that you could be there. Have things changed now that we have more access to our family members and friends in order to be supportive of them and know what's happening to them medically?
Yes, that has changed very significantly. And the state and the city do give us some basic guidance as to how to craft visitation policy for our patients that are admitted and their families. But you'll notice that if you go from hospital to hospital, different hospitals have different specific requirements for their patients and for even different units within the hospital. For instance, maternity ward would have one set of policies for those patients, and whereas the medical ICU would have a different set of policies on visitation. In our hospital, our requirement is that patients, folks visiting patients that are admitted to the hospital be fully vaccinated against COVID-19 and also maintain a mask during that visitation. But we do have visitation hours, we're happy to say, and so patients, families can spend that important time with their family members while they're admitted.
That's super, and things are ever evolving. So
Yes.
Things are changing all the time, and it's becoming more and more accessible. Because we learned over the years that it's so important to have a family member there. Patients do better, people do better with the stimulation, and it's just so important for the family and for the patient.
It's critical, and one of the saddest times I think for us as doctors was when a patient would die and family was not there during the height of COVID. It was very painful for, of course, the family members, but also for the staff, nurses and doctors who were in fact with those patients when they passed. So it was just a terrible situation all around, and we certainly will take the guidance from the state and the city if there were a spike in cases, because it's conceivable that visitation would have to be temporarily suspended again if admitted cases to the hospital were to rise. So of course we will follow that guidance very carefully.
Let's jump into the medicine.
Yes.
Last year we've done this for the last couple of years, and we've gone from no vaccines to multiple vaccines to boosters with vaccines. And one of the hottest topics of conversation amongst people is which vaccine Should they get a reboost with it? How many times? So let's go over some of we're going to do really the medicine now for our remaining portion of the segment. And the idea about vaccination, clearly crucial. Maybe I'll even ask you in sort of a devil's advocate question. If so many people have gotten the new Omicron variant and so many people have been vaccinated, if somehow I slipped through the cracks and I didn't, should I get one now?
Yes, you should get vaccinated today if you've not achieved, if you've not received your initial series of vaccines. The answer is yes, because the Omicron variant, as you alluded to, is the dominant form of the disease. Still, many of the people that we're seeing that do poorly with this disease are those who are unvaccinated. Consequently, it would make sense that if a patient has not been vaccinated, yes, they should initiate that series with one of the vaccines that we have available to us.
So a lot of people got the first dose and the second dose. They had their card, they were happy, they got their vaccination card, and they went around doing their usual everything. Now the concept of a third or fourth dose, the boosters have come out. And what's the guidelines and what's your medical opinion with regard to the boosters for patients? Is it everyone? Is it people who are just very sick or people who are older, immunocompromised? And things have changed over time. And initially it was thought that it would be more for just people who were immunocompromised or older. Then the guidelines said more people can get it. So maybe enlighten us with it, because a lot of people are still out there who, and I see this in my practice very commonly, who will say, I had my vaccine in August of 2021, and I got COVID. I was tested positive for COVID 3 months later, 6 months later, and now I'm debating whether to get another shot. But I've had COVID and I've been vaccinated at least with 2 shots. What do I do now? So that's sort of where a lot of people fall right now, and I see this very commonly in the practice.
Yeah. I have the same experience with my patients, and a lot of people are interested in what they should do. Doctor, I got this vaccine. Should I get a different vaccine? And should I get a booster at all? Should I get the second booster? And the answer is I would recommend getting the recommended booster based on what the CDC recommendations are. And what does that mean specifically? Of course, with the mRNA vaccines, those that everybody will recall, there are 2 of those. We have the Pfizer and the Moderna vaccines. They're 2-dose series, and for all patients that have, except for children under the age of 12, it's recommended that those people get a booster dose. That's the 3rd shot. Now, for those who are above age 50, the current recommendation from the CDC is to get a 4th booster dose, a 4th dose in the series. And then the question, well, what is the data for that? And it's very interesting. A lot of this data comes from Israel, where they've really done a great job at collecting this data in terms of efficacy. And they look at a variety of different parameters. They look at prevention of disease. They look at risk for hospitalization, and they look at risk for death. And even although there is very good data for the 3rd vaccine, the 4th dose has been a little bit controversial in the literature. The Israeli data, whereas it had previously showed there was a 78% risk reduction in terms of death with the 4th dose of the vaccine, there was some concern that the benefit that patients achieved with that did taper off over the next few months after receiving the dose. So it calls into question, are we going to need a 5th dose and all? And then really the jury is out on that, and we don't know where this leads. But when you have a vaccine that is safe, available, free, and really with very, very few side effects, I really advise my patients, and a lot of my patients, of course, are diabetes patients, are on dialysis. And I know we share some of these patients together. They're some of the sickest people out there because of their other comorbidities, and I certainly want to offer them any preventative measure that I can to make sure that they're as healthy as they can be for as long as they can.
So just to finish off on vaccines, is it somewhat counterintuitive that each of the vaccines are the same? That it's the same material that you're getting from the 1st, 2nd, 3rd, and 4th. Many of us are concerned about the fall. We're coming up to summertime, but the fall and the winter, because we think this kind of virus might be more frequent, and we've seen our waves occur a lot of times in the colder weather. So the idea that, do you believe that they're going to be changing the vaccine in the future to have more of a, they say an Omicron backbone basically mimicking the more common viral variant that we have right now, Omicron, rather than some of the original wild type that we call them that occurred?
Sure, I think they're certainly working on those vaccines. The question is going to be how this particular virus will continue to change, and once the vaccine is approved, how efficacious it will be with the new variant that circulates. I think that those are legitimate concerns. But yes, many of the drug pharmaceutical companies are working on this question, this problem, and with the data, of course, we can't prejudge it, but the data needs to demonstrate efficacy and safety, most importantly, because patients have to be confident in the products that we give them being safe. That's a lot of the hesitancy we've certainly seen in our practices. People are afraid, oh, is this going to cause a problem for me? Is this going to be worse than actually getting the condition? What we've seen is the vaccines have been remarkably effective, remarkably safe for our patients, and I'm hopeful that whatever vaccines will emerge will have that same level of confidence so we can recommend it to our patients.
So even if you're vaccinated, you can still get COVID.
Yes.
You can get COVID-19. It's a common virus right now. It can be passed along one person to the other, as we all know, through droplets, through being airborne. So tell us, if someone does get COVID and they're tested, whether they were mildly symptomatic or just tested because they were going to go on an airplane flight or vacation or seeing someone in their family, tell us a little bit now about what are the guidelines that if you test positive, what do you do? You have all these at-home tests are readily available, and for whatever reason, if you wake up Tuesday morning and you have the sniffles and you test yourself and that second line turns out positive and you have COVID-19, and these tests are very sensitive, the idea, what would you do? Do you go to the doctor? One thing you don't do is run to the hospital unless you're feeling sick, obviously. But the question comes down to is, for all of us out here, what do we do? And I think what I'm hearing so much from friends, family, colleagues, a lot of people don't know what to do. And I get a call, and I'm a neurologist. I'm not an internal medicine physician. I'm not an infectious disease doctor. And they say, what do I do? And we talk about risks, and I'm familiar with the risks, and you'll go over them a lot more. But the idea is so many people just say, I'm just going to stay home. No one's going to bother me. And many times that is the right answer. But I'm just going to stay in my house, close the door, no one's going to come in, and I'll see you back in a week. So tell us, if someone does test positive, what they should do.
Well, first of all, they should ascertain and think for themselves, how do they feel, I think is the first question. And some people, and I'm sure you've had these patients, they will tell you, I feel nothing. I literally feel nothing. I just did a test. I'm going on vacation, and I had to do the test for the trip, and I tested positive. If you feel nothing, really there's nothing to do in terms of treatment. Certainly, you should be isolating yourself from others. You don't want to pass it on. Nevertheless, there's no medicine to take or anything like that. If you become mild to moderately symptomatic, well then that requires either a call or a televisit or a visit to a primary care doctor. And each practice, of course, has a different approach to these kinds of cases. Some doctors are taking sick visits at particular times of the day. Some doctors will do the visits via the telephone or video chat. And it's actually one of the benefits of this whole thing is that we've been able to use telemedicine to reach patients that we would have been otherwise unable to reach in the context of a typical office visit. And your doctor needs to help you make the determination whether or not you need additional help. Now, if you have a severe case of COVID, if you're short of breath, you're turning blue, your mental status is changing, that's the time to really head to the emergency department, because that's a reflection that your oxygen level might be low, and there could be other more serious problems going on. But if you're mildly to moderately ill, cold-like syndrome, flu-like syndrome, that's the kind of case that should be handled as an outpatient with a primary care doctor. Then, of course, the question comes, what medicine, what treatment? So in the hospital, what we do is we have a particular protocol, the severe cases. We only admit severe cases to the hospital. And those patients, we give two drugs, a drug called remdesivir and a drug called dexamethasone, which is a steroid to decrease the inflammation of the lungs. And these drugs have demonstrated pretty good efficacy with respect to decreasing the progression to more severe disease. But as an outpatient, and those with mild to moderate disease, the ones that don't have low oxygen levels, the whole idea of treating those patients is we don't want them to get severe disease. So treating them early is best. And generally speaking, the symptoms have to be within 5 days of onset. So if you have a mild to moderate case of COVID and it's within 5 days of onset, you might meet criteria for therapy. And what's the therapy? Well, there are two. One is a pill called Paxlovid, and the treatment is 3 tablets of this Paxlovid twice a day for 5 days. And another approach is a monoclonal antibody infusion. And the monoclonal antibodies, there have been a whole host of them that have been available on the market, but as the virus has changed, so have the monoclonal antibodies. So the one that's currently available for use in our hospital and certainly in around New York State is a medicine, and I'm going to butcher the name, but I'm going to try it anyway, bevtelovimab. And this monoclonal antibody, it's a one-time infusion, but the question becomes, to whom do we give these monoclonal antibodies? To whom do we give Paxlovid? And generally speaking, we give these medicines to people who are higher risk for progression. Now, who are those people? Those tend to be the people who are overweight or obese, people that have diabetes, chronic kidney disease, have cancer, anything that suppresses your immune system. I know you treat a lot of patients with multiple sclerosis. Those people would be candidates for monoclonal antibody infusions or Paxlovid in order to prevent their risk for disease progression.
How about preventative therapies? There's a monoclonal antibody from AstraZeneca.
Yes.
And just for everyone, I don't know if everyone realizes that if the last initials of a medicine is MAB, that's something called a monoclonal antibody. So that's where, however long the beginning is, if you see the word MAB at the end, that tells you monoclonal antibody. So there are monoclonal antibodies that we can give to people who might be at high risk. As you mentioned, I take care of a lot of patients. I run a large multiple sclerosis center on Staten Island. And there are patients that we have on medicines for MS that dampen or immunomodulate or suppress the immune system. And in those patients, many of the time, and we're looking into this right now, it's become more commonly used in my literature and through our patients, those patients who might be at increased risk because of these medicines to be on preventative therapies. Hard to get, and you said the federal government has to do it, it's not as easy, but what we're looking into, and maybe just for our wonderful audience, just the idea that if you are on immunosuppressant therapies, if you do have cancer, sometimes we use these medicines now to prevent this infection. Yes. So tell us a little bit about it.
These monoclonal antibodies, the one that we're talking about is called Evusheld. And this Evusheld is an intramuscular injection, so it's administered in the doctor's office, small injection in the muscle. And the idea of this Evusheld is that it will prevent infection with patients. Now, again, who are the subset of patients that would be most likely to benefit from this type of therapy? Well, there are some people, we give them injections of the vaccinations, of the Pfizer vaccine, Moderna, whatever, but for whatever reason, they are immunosuppressed and they will not mount a sufficient immune response to those medications. So if you have a very sick patient with a very sick immune system, giving them this specific monoclonal antibody has been demonstrated with great efficacy to decrease the risk for those people contracting COVID. So whereas before we were talking about the monoclonal antibody as a therapeutic agent, this is using a monoclonal antibody as a preventative agent.
And that also means because a lot of the medicines that we give out to our patients may dampen or affect their immune system so they can't mount the response from the vaccine. Correct. This basically gives them almost like a restored immune system to go against COVID-19.
That's right.
Let's touch base on post-COVID syndrome. We're seeing so much of this, and I'm seeing so much of this. There was a time in my practice that almost half the patients coming in had symptoms related to COVID, particularly brain fog, memory issues, headaches, dizziness, numbness, tingling. And we saw a good fair number of people who also had post-vaccine symptoms. Not as much, obviously, and those were much shorter lived. What are you seeing with regard to, and you're an endocrinologist, what are you seeing with our patients after COVID?
The residual effects from COVID are literally go from head to toe. I have people, one of the big problems with COVID, of course, is that patients can get COVID pneumonia. The infection of that, infection at really attacking the lung. And many patients, after COVID has gone away, or at least in terms of how, the fact that the patients have recovered, they still tell me, doctor, it's hard for me to walk up a flight of steps. I still get short of breath. And these are some of the symptomatic things. I've heard patients complain to me about psychiatric symptoms, anxiety, depression. I'm sure one of the neurologic complaints they're complaining to you is about cloudy thinking. Some of my patients complain about changes in their bowel habits even, whereas before they were constipated, now they're having diarrhea, and they've fluctuated from one to the other. So any organ system that you can come up with really can have some residual symptoms in that organ system. But those are the symptomatic issues. Separate from those, there are some permanent problems that people get. Sometimes the COVID causes damage to the heart. Sometimes there's damage to the kidneys. And those are not easily resolved, and sometimes they can be permanent problems. So there's a symptomatic component, which we do think of as this kind of long COVID or the long haulers. And then, of course, there's the others that are getting just chronic medical problems from the condition that really, unfortunately, don't seem to go away.
And obviously, there's a lot we don't know. We're still in the 2-year period about since COVID became rampant and epidemic and pandemic. The idea is that when someone comes in 2 or 3 months with memory problems, anxiety, things that we talked about now, they say, when is it going to get better? We used to think that about 6 months was the window of time. Now I'm seeing patients who've had this for a year.
Yes.
So the window of time is getting longer and longer, and supportive care, and there are some medicines that are being looked at, again, looking for evidence-based medications that may help concentration, memory. So we are investigating, doing a lot of different things with our patients. But right now, a lot of it is we don't know. And it's a very difficult situation. And I'm still seeing a lot of patients, and I'm sure you are too, still having a problem with their sense of smell and taste.
Yes.
Especially with the Omicron variant has less effect on smell and taste, but a lot of people who had the Delta variant very early on still are having problems with their sense of smell or taste. They're using the terms, everything smells like soap. Things have just not gotten better. So we're very hopeful that they'll get better. Anything specifically that you're seeing? And I'm saying this a lot, we have only a few seconds left, so all of our viewers will know that they're not unusual. That if you smell soap, yes, a lot of patients are saying it. If you're feeling tired, a lot of patients are saying it. I think you mentioned before people are having worsening of their stomachs, GI tracts, thyroid. All these things are not atypical. And I'm seeing we only have a few seconds left. If there's anything you want to close with regard to what you're seeing, we'd appreciate hearing it.
No, I mean, I think I'm certainly very happy to see things are improving in the hospital. The number of hospitalizations are down. COVID is likely here to stay. We're going to have to work with it. We can't isolate ourselves from it completely, but we have to keep ourselves vaccinated in order to prevent development of severe disease. Because if we get a cold, that's okay. But if we don't want to wind up in the hospital, we certainly won't want to perish from this condition. And if we do all we have to do to prevent it, we'll be in good shape.
Thank you, Dr. Otterbeck.
Yes.
It was a pleasure, and thank you, everyone, for watching us tonight, and stay safe.